Hi guys. Hopefully you're having a good Tuesday day and hope everything's good for you. Um, I want to talk to you about several things today in the book, and I'm going to try to refer to you to some pages. So if you don't have it yet, maybe go get your book and something to write on for your notes, because remember, I want some of those notes on my lectures in your notebook at the end, okay, which you also get points on. Okay, I want to talk to you about premature contraction. Now, obviously, premature contractions come early, okay? And there's premature atrial, premature junctional, or premature ventricular contractions. And usually it's because a focus, an area in the heart, in the atrium, in the junction, in the ventricles, is irritable, okay? So it just fires. Have some of my great coffee while I'm talking to you. Okay, so let's look. I'm over on page 88, and I'm looking at box 7.2 on the right-hand side. A premature atrial contraction. Okay, the underlying rhythm, usually regular, but obviously irregular with a PJC. The rate is that of the underlying rhythm. Okay, the P waves are associated with PACs are premature, and they appear abnormal in size, in shape, and in direction. Okay, the abnormal P waves are commonly found. Sometimes they're found hidden in the T wave. So if they're found hidden in the T wave, the T is going to be enlarged. Okay, it's going to be kind of peaked. Okay, and distorted just a little bit of the contour of the T wave. Usually, the PR is normal duration, but if it's hidden in the T wave, then the PR is not even measurable. Okay, the QRS is premature. Okay, because if you get a PAC, and it's usually 0.10 or less, which is normal duration. Okay, so let's kind of look at some of this a little bit. Let's take a look at page 89, and I 89, and I'd like you to go to the center strip, which is 7.7. If you almost go to the end of the strip, remember you're looking from left to right when you always read a strip, you'll see a beat that occurs early. So this is an NSR, a normal sinus rhythm, with a PAC, premature atrial contraction. And you can see how that P wave looks a little different than the rest of the P wave. You also look at the bottom strip, strip 7-8. You have a normal sinus rhythm with a PAC, another premature atrial contraction. Okay. Now sometimes, I don't know if this is a great place to bring it up, but I'll do it. Okay. Sometimes premature contractions, premature atrial, premature junctional, or premature ventricular can go on the end of a couple of normal beats and keep repeating itself over and over. So what you get is something called group beating. In other words, you got a group that kind of hangs out together and it occurs over and over. Okay? And this is called gemening. And if the premature contraction, premature atrial that we're talking about in this case, but could also be premature junctional or premature ventricular, happens with one normal beat, you count the normal beat and the premature beat together. So if there's two of them, it's bigeminy. Bi meaning what? Two. If the premature beat couples with two normal beats, got to count everything together, then there's three beats there. I can't do the the Star Trek sign. There's 3 normal beats there, okay, but one's premature. That's trigeminy. If the premature beat couples with 3 normal beats, right, that's quadrigeminy because you count everything. So a premature beat and a normal beat happening over and over again, not just once or sporadically here and there, is bigeminy. A premature beat coupling with 2 normal beats is trigeminy. And a premature beat coupling with 3 normal beats is quadrigeminy. Now, how do you know whether it's atrial, junctional, or ventricular geminy? Because you look at the beat, and if you look down right now to the bottom of page 90, and if you look at strip 711, do you see the premature beat there? Just looking from the left. The premature beat is the second QRS that's appearing, okay, and it's a premature atrial contraction. Why? Because it's upright. And why? Because the P wave looks different from the other P wave. Okay? And so that's premature KB. So it's premature bigeminy, okay? Premature atrial bigeminy. Notice that on 91, you have trigeminy. Why? Because you have, if you go almost the way to the end of 712, okay, on page 91, almost to the very end. I'm looking at 1, 2, 3, 4, the last 4 beats that occur. The second to the last 4 beats is an atrial beat. And notice what? It comes early. So it's a PAC. But it couples with what? With 3 other, making sure I'm right here, 3 other normal beats. So it's atrial trigeminy. Okay? And if you look at the bottom strip, okay, we have premature atrial contractions. But it's occurring, the PAC is occurring with 2 normal beats. We've got a PAC, premature atrial contraction. All right, now, so you always look at the P wave, and if it looks different and it comes early, it's a premature contraction. But it depends on what the P wave looks like in that premature beat. It obviously looks different, okay, than the other P waves, and it's premature atrial. If it has, and this is something you got to write down, and I'll try to go slow here. If the premature atrial will come either before the QRS or after the QRS or buried within the QRS. Now, if it's buried, you obviously can't see it. Now, sometimes premature beats are not conducted. So if you look at page 93, you see 3 beats from the left. They all look normal so far. They all look alike. Okay. But the next one, the 4th beat, is premature, right? But it's a normal sinus rhythm with an accelerated PAC. Now, why do they call that accelerated? Because it's a little faster than normal, okay? And accelerated beats, especially accelerated atrial beats, okay, are, in this case, non-conducted PAC. Let me look at this for a second, because I feel myself making a little bit of a mistake and I need to go back here. So it's a normal sinus rhythm with a non-conducted PAC. Non-conducted means you don't see the QRS. Okay? You see just the beginning of the beat, but it's not the whole beat together. So it's a non-conducted premature atrial contraction. Take a look over on page 95. What do we have? PAT, paroxysmal. And what did I say paroxysmal means again? Sudden. We have a paroxysmal atrial tachycardia. Well, let me ask you a question. How do you know it's atrial? Because I don't see any P waves. Okay, but the P waves are hiding within the QRS. All right? Or they're hidden within the T wave. So the T wave looks a little bit larger and more pronounced than it normally would. Okay, on 720, I have an NSR with a PAC, premature atrial contraction. Okay, once again, I'm going to ask you, where are the P waves of that last complex, that fourth complex on 720 going from left to right? Where are the P waves? They're hiding within the T wave. So it's premature atrial contraction. And then we have a PAC, premature atrial contraction, initiating a PAT, paroxysmal atrial tachycardia. Okay, I want you to take a look, just for a moment, at strip 722 at the bottom of page 97. Notice we have some waves that look sawtooth. And if you go down there to 722, page 97, notice every time we point them out, we call it an F wave or a flutter wave. There's several F waves that you're going to look at here. This stands for flutter. Okay? And flutter waves occur 250 to 350 per minute. Notice the atrial rhythm is regular and the ventricular rhythm is regular, but it could also be irregular. Here's what I mean by that. These are 1, 2, 3 F waves. Well, they say it's 4 prior to every QRS. Well, if it's 4 to 1, 4 F waves to every QRS, then the rhythm is regular. But if it goes 2 to 1 to 4 to 1 to 5 to 1, the ventricular rhythm would be what? Irregular. Now, sometimes the flutter waves affect the whole baseline to such a degree that there is no isoelectric line between the F waves or the flutter waves. The best thing about this strip is you invert it and you look at the F waves. If the F waves look sawtooth, then they're flutter waves. Okay. Let's take a look at 99, 7.5. The rhythm is what? Regular to irregular. It depends on the AV conduction because the AV node, okay, is only accepting maybe every second or third or fourth beat. If it goes 2 to 1 or 3 to 1 or 4 to 1, then the ventricular rhythm is regular. So if you look at 7.5, the PR is not measurable. Why? Because there's no P wave. The P waves are sawtooth, and by this they mean they're talking about the F waves or sawtooth. And the QRS is normal, 0.10 or less. Okay. Now what can cause flutter is several things. Heart failure, decreased blood flow to the heart can cause pulmonary embolism. Remember, an embolus is a blocked artery by fat, by air, or blood. Can also follow heart surgery, hypertension, hyperthyroidism, pulmonary embolism, older age. I won't go on to that too much. Okay, can cause flutter. And then if you go over to page 100 and 101, you look at atrial fib. In atrial fib, there's no atrial contraction. The atrium are just shaking. They're fibrillating. What's been likened to a bag of worms. And if you look at figure 7.28, those are, some of them, not all of them, are fibrillatory waves. Fibrillatory waves looks like I've got bad Parkinson's disease and I'm trying to draw a straight line on the board. That's fib. So there's no atrial contraction. The PR is not measurable. The QRS complex is usually 0.8 or less. Keep looking at this. The worst thing and the most potential thing that you need to focus on in atrial fib is forming a blood clot. So you need to make sure, because why? Because the blood in the atrium it's standing still. It's going to the ventricles by gravity. In atrial fib, you lack an essential component called atrial what? Kick, the atrial contraction. So by losing atrial kick, you've lost, in some cases, up to 30% of your cardiac output. Okay? I'm looking, guys, just looking down at these strips that I want you to know. Okay, now what's the difference between a PAC and a PJC? A premature atrial contraction and a premature junctional contraction. Well, let's go PAC. Obviously, the PAC comes what? Early. The P wave looks different than the other P waves to the left. But in a PJC, in a premature junctional contraction, the P wave also looks different from the P waves on the left. Okay? So if we're looking at this, the basic rhythm could be in a junctional rhythm, the PJC could look either regular or irregular. Basic rhythm is sometimes a basic rate of maybe 72. There's sinus P waves with the basic rhythm, but with a PJC, the P wave can be inverted, upside down. You go, why? Well, because the junction is depolarizing the atrium from below. So remember how the electrical current goes from the SA node to 3 branches, okay? Anterior, middle, and posterior what? Internodal pathways. And it goes down to the AV junction. And then it pauses for a moment, a brief pause. And then it goes to what? The bundle of His, okay? To the right and left bundle branches, into the Purkinje fibers and the ventricles, right? So junctional contractions, especially I'm looking at page 141, you may go back to that. Okay. This junctional contraction has no P wave. And junctional contractions, a lot of times when you see them, will have no P wave. Why? Because the P wave is usually inverted and it comes before the QRS or after the QRS, or here we go, buried within the QRS. So if you see in a junctional contraction, if you see a QRSs with no P waves, don't go, I'm not sure what that is. It's a junctional contraction because the P waves can be buried. In this case, if you look at page 141 and you look at 8.5, where is a P wave? it's after the QRS. And you kind of see it there. It's right after the QRS. Okay, but look at strip 8.6. Take a look at that very closely. Look at the T wave. The T wave is kind of bigger than the rest of the T wave. And why is that? Probably because the P wave to the PJC, usually inverted, is buried within the T wave. And so it looks elongated. See, it tells you that. Sinus P wave, basic rhythm. P wave associated with PJC is hidden. Okay. And the QRS. Now I thought, my mistake there, because I thought it was buried within the T wave, but it's buried within the PJC. So anything you see that's junctional can have inverted P waves prior to the QRS, after the QRS, or buried within the QRS. They say this one is buried within the QRS. Cool. All right. Take a look over on page 142. Take a look at the bottom strip, strip 8.8. Normal sinus rhythm with paired PJCs. Now, do you see the inversion of the P wave? They're inverted, they're not upright. Take a look at the rest on the left or the rest on the right. They're upright. These are inverted. Any inverted P waves prior to the QRS, after the QRS, buried within the QRS is PJC. Think of what else I can show you. Take a look at page 145. What's going on there? You have inverted P waves. And what does inverted P waves mean? Junctional rhythm. Okay. And all the P waves here are prior to the QRS. The other thing to look at, remember when you're using those 5 things to analyze, those 5 criteria to analyze a rhythm. You look at the rhythm, is it regular or irregular? You look at the P waves. Okay, these are inverted. Inverted P waves mean junctional. Okay, and the other thing here is you look at the rate. And what is junctional rate? 40 to 60. Well, here the rate's 35. Okay. So this is really, it's a junctional rhythm, but it's at a rate of 35. Okay. Take a look at page 811. No P waves, but QRSs. Okay, rate of 47. Where's the P wave? It's hidden within the QRS, hiding. What kind of a P wave? Inverted. Now, if you go down to the bottom, I think I said this a moment ago, go down to the bottom of page 145, and you see inverted P wave. So what kind of a rhythm is this? Junctional. What's the normal rate of junctional? 40 to 60. Okay. But this is a rate of 94. All right, I'm going to introduce you to a new concept. Sometimes in ventricular and junctional rhythms, they're above, the rate is above its normal rate. Well, junctional can go up to 60 beats per minute. This rate is 94. Any rate above 60 for junctional up to 100 is accelerated junctional. If you take ventricular, what's the rate of ventricular? 20 to 40. Good. What if it goes above 40 up to 100? It's accelerated ventricular. In fact, it's what we call an IVR, accelerated idioventricular rhythm. Idio means occurring within that area, okay? Peculiar to that area. Look over on page 146. I don't see any P waves. Once again, probably junctional. But what's the rate? 84. It's above 60, so how would you know it's junctional? It's accelerated junctional. It's above 60 and up to 100, because if it's greater than 100, then what? It's junctional tachycardia. For ventricles, okay, for idioventricular rhythm, 20 to 40, if it's above 140 up to 100, it's an IVR. Well, it's above 40 up to 100, it's accelerated IVR, idioventricular rhythm. Once again, idio is a combining vowel in medical terminology. It means above. Now, but it can't go above 100, because if anything goes above 100, it's tach. Now we get over on page 147, and we're going to talk about heart blocks. Now, the most common heart blocks are these. You can write these down, I'll go slow. First degree, you can write a 1 with a little thing over there, degree. Second degree, and second degree happens in two types of second degree, only one type of first degree. Second degree, two categories. Mobitz 1, M-O-B-I-T-Z, Mobitz. Who would name their child Mobitz? This guy was born in the 1800s. He didn't die till sometime in the 1900s. He did a lot of research on heart block, so they named the heart block after him. This is Mobitz 1 and Mobitz 2 are two types of second degree AV blocks. AV, atrioventricular. And third degree heart block. Now, third degree is what we call a complete heart block. Complete. Now, look at the bottom of page 147. What do we have? First degree AV block. First degree atrioventricular block. I want you to take a look at example 1 over on page 148. 148, figure 819. It's great. Okay. I know I've made a few mistakes today. I apologize. Okay, just try to stick with me. I'll pull you through the quagmire. All right. That's a good word, isn't it? Okay. What does this look like to you? Well, to me, it looks like an NSR. In this case, it happens to be a sinus bradycardia. But take a look at the PR. That's another thing we analyze, the PR interval, when we're trying to figure out what type of a rhythm we have on the EKG, PR. Notice what we got right away, and you don't even have to, you should measure it, but you can also look at it and say what? It's prolonged. How do you know? PR is only 0.12 to 0.20, okay? 0.12 to 0.20 seconds long. What is this? Well, let me look at the second beat on 148, and I'm going to guess because I don't have my calipers here. It looks like it goes out 3 more blocks almost, if not 2 more blocks than the normal PR. Because a normal PR can't go above 0.20, which is 1 little block wide. So it's either 3 little blocks or 5 little blocks wide is normal. This goes above 5 little blocks. Now it's very easy, if you listen to what I'm about to tell you, to identify first degree AV block. Here it is. Usually an NSR with a consistent prolonged PR. Kind of rhymes, right? Now I'm going to give you several of these things to kind of help you identify. NSR, consistent prolonged PR. Now when I said consistent, that's not normal. It's prolonged greater than 0.20, right? It's above 5 little blocks wide, but it's consistent. wherever you see the PR. In other words, if it's 0.28, it's going to be 0.28 here, 0.28 here, 0.28 here, 0.28 here. That's what I mean by consistent. So it's prolonged, but it's consistent. So NSR, consistent prolonged PR, is a first degree AB block. Real simple, not complicated. Go down to the bottom of the page, page 148. First degree AB blocks, identifying features. That of the underlying what? Sinus rhythm. Both atrial and ventricular rates will be the same. Why? It's a sinus rhythm. Who's calling the shots? The SA node, the sinoatrial node in the posterior wall of the right atrium. We got one drum major here. He's calling the shots. Okay. So the only thing abnormal about this is consistent prolonged PR. And the QRS is usually normal, 0.10 or less. Now, but the only thing I want to hear from you, if you say, just you're reporting this, I want you to say simply this. It's a first degree AV block. The rate is, in this case, we look back up to 819 on page 148, 40 AVs. First degree AV block, 40 AVs per minute. Okay, real simple. You see on that, by the way, you noticing it? A little bit of a U wave. Personally, I wouldn't report U wave. That's just me. Okay. So how do you report a first degree AV block? I'm going to go back to the top of page 148. Look at the strip. You got an NSR, first degree AV block, 48 beats per minute. You have an NSR, first degree AV block, or just say first degree AV block, rate of 48. They should know what typifies the first degree AV block. In other words, you want to count out and cut out all the language you can and make it simple. First degree AV block, rate of 48. You may have to say NSR, consistent prolonged PR. But if I ask you, or somebody that's interviewing you says, okay, explain to me a first degree AV block. Simple. NSR, consistent prolonged PR. There it is. Okay, but when you're reporting first degree AV block at 48, cut out all the other superfluous stuff. Okay, still on 148, go to the bottom. Second degree AV block, remember? Two types. What are they? Mobitz 1 and Mobitz 2. Now before I get there, I want to show you something here. If you can look. Look back page 148 under the second paragraph. What's the etiology? Remember etiology, the cause of a disease, okay, of a first degree AV block, ischemia, injury to the AV node, secondarily to MI. Okay, just know one, ischemia. Okay, what's ischemia? A temporary reduction in blood flow to an area. Okay, real simple. This area is probably what? The AV node. Very important concept. Always remember, in order for electrical signals to get down to the ventricles, they must traverse the normal electrical conduction pathway. SA to AV. How? Anterior, middle, and posterior internodal pathway. And you also got what? Bachman's bundle. And over to the left ventricle. What happens in the AV node? Well, the proximal end of the AV node, the very tip of it, doesn't have anything that can conduct anything. So everything slows down. Why? To allow blood, which is viscous, to go through the atrioventricular valves. What are they? On the right side, tricuspid. On the left side, bicuspid or mitral. Down to the ventricles. So the ventricles can fill, okay, with blood. All right. And then where? Down the AV node, to the AV junction, to the bundle of His. Down the bundle of His, to the right and left bundle branches, to the Purkinje fibers, to the ventricles. Okay. From now on, just give me one thing that can typify a rhythm. You want to memorize everything, kind of record in your head. I wouldn't suggest it. Just one thing. Now I want to go over to second degree Mobitz 1. Okay, once again, I'm going to give you a word picture. Word pictures are very powerful. Word pictures also tell me you know what you're talking about. Second degree AV block type 1, also called Mobitz 1. I would just say Mobitz 1, I like it. Why? It cuts out a lot of those words. Second degree AV block type 1. Mobitz 1. They're real simple. Okay. Here's my little remembrance for Mobitz 1. The PR lengthens from cycle to cycle to cycle. In other words, it gets longer. PR lengthens from cycle to cycle to cycle. Punctual P, drop QRS. PR lengthens, cycle to cycle to cycle. Punctual P, drop QRS. And you should say that to yourself over and over again. If I'm interviewing you, okay, for a monitor tech, I want to know that you know that. Or an ER tech. Okay. Very simple. Okay. Now, take a look at the top of page 149 as the example for a Mobitz 1. Look at the PR on the left. Probably, to me, it looks normal. Okay? What do you mean? Well, it looks like 0.20, which is a normal PR. I'm on the very left, 149, strip 820. The PR on the first beat looks normal. Wouldn't you agree? I know the ST segment's depressed. Forget about that for right now. Look at the next beat. What happened? The PR goes above normal, okay, above 0.20. What happens next? There's a punctual P and a drop QRS. You see it? The PR lengthens from cycle to cycle to cycle, punctual P, drop QRS. Now, a lot of these things, a lot of these blocks, you need to report, you need to be aware of. And why is that? Because a person with heart blocks, even if it's benign, like no big deal, can go on to develop greater heart blocks that are a big deal. But I would say to you, first degree is probably not a big deal. First degree heart block. Okay. Mobitz 1. Okay, now as we progress up to third degree, let me just tell you, every time we go to something higher, like we go to first degree to Mobitz 1, from Mobitz 1 to Mobitz 2, from Mobitz 2 to third degree, every time we do that, the potential for a more serious arrhythmia occurs. Okay? So I'm in Mobitz 1. PR lengthen, cycle to cycle to cycle, punctual P drop QRS. Is that necessarily a big deal? Probably not. Okay. But you should be aware of it. You should report it. Why? Because it can go to a Mobitz 2. And Mobitz 2 can go to a third degree with little or no warning. All right. So here Mobitz 1, an MI. Myocardial infarction can cause a Mobitz 1. Okay. So what do you do to report this? Well, I would say Mobitz 1 at 72 beats per minute. So I got a Mobitz 1, 72 beats per minute. Do I have to tell them all the rest of the stuff? No. But if I ask you, if I'm an interviewer, or I come up to ask you, explain Mobitz 1, you're going to do the whole word game. The PR lengthens from cycle to cycle to cycle, punctual P, drop QRS. All right. You also have to review, if there's problems with the heart, patient medications. Because certain patient medications can cause a Mobitz 1, like digitalis. What is dig? Should know this, common drug we use. It's a cardiac glycoside. It comes from a plant they call foxglove. Now somebody was either fooling around or something years ago, and they chewed a little leaf of ditch. And guess what happened? Their heart rate slowed, okay, and they had more, sorry, I just did that with my hand. My middle finger here is really swollen, so here, never mind. Okay. It's just really swollen, so I'm trying to get you to kind of see it. Okay. Why did I tell you that? It's not going to be on test. Okay. Let me go back. So it slowed the heart rate and it increased the force of contraction. Digitalis slows the heart rate and it increases the force of contraction. They call DIG a negative chronotropic and a positive inotropic drug. Negative chronotropic and positive inotropic drug. Chronology, time. Okay. So negative chronotropic means we're decreasing the speed of the heart, the rate of the heart. And positive inotropic means we increase the force of contraction. But you got to watch it when a patient's on DIG. Okay. So DIG can be caused by what? DIG can be caused by. Mobitz 1 can be caused by digitalis. It can also be caused by beta blockers. Give you a beta blocker. Metoprolol is a beta blocker. What's it do? It blocks beta 1 receptor sites in the heart. If you put something in beta 1, like my coffee, like cocaine, like Coca-Cola, the heart rate's going to go crazy. It's going to go up. If you block it with a drug like metoprolol, it shouldn't speed up, it should slow down. So atrial fib can be above 100, okay? It can cause problems. So what are you thinking of with atrial fib? Probably put them on a beta blocker maybe, or a calcium channel blocker. So beta blockers, calcium channel blockers, and DIG can cause Mobitz 1. All right, now, tell you something else just by the point here. I mentioned to you potassium. Potassium is the primary intracellular electrolyte. Sodium is the primary extracellular electrolyte. Normal potassium is very important in the blood. 3.5 to 5.0 is normal potassium. Tell you something else. The patient may be on a very famous drug that's probably been around since the 1950s. If the patient says, I'm taking a water pill, that can deplete potassium. Okay, it can cause potassium to go down. So guess what we give a person that their potassium is depleted from them going to the bathroom all the time, okay, urinate. We give them a potassium supplement. And a lot of times those people will say, well, I don't need to take this big pill every day. I'll just take a banana. Really? Guess what? You have to take 40 inches of banana to get your minimum daily requirement of potassium. You need to take your potassium supplements or it can cause heart dysrhythmia. Normal potassium 3.5 to 5.0, and this is important. A small m, M like mom, a big E like equator, a small q like Quebec, MEQ per L, 3.5 to 5.5 MEQ per L, milliequivalents per liter. Okay, normal sodium, 135 to 145 milliequivalents per liter. How about, look at what I wrote here. How about calcium? 8 to 10 milligrams per deciliter per DL. Calcium, 8 to 10 milligrams per deciliter. Now, people have died from just having an imbalance in electrolytes. Okay? Electrolytes are charged particles. Now, I know a lot of women were having problems in marathons. They couldn't figure out what was going on. Guess what? They depleted their sodium. One way they did that, they drank water. Over and over and over again, they just filled up on water. And that caused low sodium. Sodium is natro, N-A-T-R-O. Hyponatremia, emia is blood, hypo below. Okay? Hyponatremia can lead to cardiac dysrhythmias, which could also lead to cardiac arrest, maybe. So electrolytes are very important. So what do I tell people that are going to go out and work out or do something? Drink electrolytes. Have something with electrolytes in them, not just water. All right, let's go to the next one. Boy, that was long, wasn't it? On Movitz 1. Movitz 2. Again, we're just on second degree AV blocks. Movitz 2. Ready? 2, 3, or 4 P waves. I won't do this with my hand. 2, 3, or 4 P waves prior to every QRS. The PR of the conducted beat remains constant. Let me say it again. 2, 3, or 4 P waves prior to every QRS. The PR of the conducted beat remains constant. All right, let's take a look at an example. Bottom of page 151, figure 8.24. What do we have here? We got a 2 to 1, 2 to 1, 2 to 1. So if I were asking you how the ventricular rhythm is, what would you tell me? It's regular. Okay. Why? If you go 2 to 1, or 3 to 1, or 4 to 1, and we're talking about P waves here, then the rhythm is regular. If you go from 2 to 1 to 5 to 1 to 3 to 1, then the rhythm is what? Irregular. Okay, but this rhythm, so the rhythm in Movitz 2 can be regular or irregular. Now, what did I say? 2, 3, or 4 P waves prior to every QRS. The PR of the conducted beat remains constant. Look at all the QRSs, then look at I'm on the bottom of page 151, strip 824. Look at all the QRSs. Look at the P waves right next to them. Look at the PR. Don't all of those look the same? They do. So what do we have? We have a Movitz 2, which is a type of second degree AV block. Now let's go back up to the top. On second degree AV block, box 8-7, top of page 151 to the right. The rhythm, atrial, it's regular. Okay. The rate, that of the underlying rhythm. The P wave, sinus. The PR, consistent, maybe normal or what? Prolonged. So the PR in a second degree Movitz 2 can be normal, okay, or prolonged. The QRS, normal. But take a look at this now. The QRS is normal if the block is located at the level of the bundle of His, but wide if the block is located in the bundle branches. Okay. So if you get a QRS at 0.12 or greater, then it's wide, which means what? The block is in the bundle branches. But if it's normal, it's at the level of the bundle of His. Okay. Now take a look at page 152. Okay. So here we have a second degree AV block, Movitz 2, in what? A 3 to 1. You go, how are you getting 3 to 1 out of that? Well, one of the P waves are kind of biphasic. It's above the baseline and below the baseline. Okay, we'll talk about that a little bit later. All right. Take a look at the bottom of page 153. Okay, now you go, well, wait a minute. Oh, forget 153 for right now. All right. Let me tell you one more thing on second degree. And I want to give you an etiology. Okay. Second degree is less common than first degree, but, ready? More serious than first degree. When I say first degree, I'm talking about Moffitt's 1. It has the potential to progress suddenly to third degree. And third degree can be a problem because third degree, you may have to be doing CPR on the victim because third degree, and even this second degree, Moffitt's 2, can go to ventricular standstill, also called asystole, with little or no warning. So if you see second degree, you can't just ignore it. You can't go get a donut, a cup of coffee down to the cafeteria and come back and let one of the nurses or doctors know, oh yeah, I got a second degree. Okay. So where am I getting this? Bottom page 151, last paragraph. Moffitt's 2 is less common but more serious than Moffitt's 1. Again, you see ventricular standstill with little or no warning? Yep. Okay, third degree. Now, third degree can be easy to see or it can be a little complicated. In third degree, none of the impulses from above are getting to the ventricles. None. So you have two pacemakers. You have an atrial pacemaker, usually the SA node, pacing the atrium, and you have a ventricular pacemaker, which could be a junctional pacemaker or ventricular pacemaker, pacing the ventricles. Okay? Two independent pacemakers in third degree. Now, you look at that for a second. Third degree, 8.27, bottom of page 153. Do you see any relationship between the P waves and the QRS? And the answer should be no. The P waves, that's a good way to kind of spot third degree, appear to march through the QRS complexes. Let me say it again. The P waves appear to march through the QRS complexes. Okay. Now, notice the T wave. In fact, notice the second one from the left. It's really tall, right? Why? Because the P wave is hiding in the T wave. And notice on the left, there's a P wave before the QRS, but then the PR is elongated in the second beat. Okay. So the P's in a third degree appear to march through the QRSs. Two independent pacemakers, one for the atrium, one for the ventricles. Let me go a little bit more on third degree. Okay. If the blockage in a third degree is in the bundle branches, the QRS will become wide. It'd be wide in width. And the ventricular rate, if it's wide, will be much slower. Cause of a third degree, CAD, coronary artery disease. Eating a lot of things with fat in them, eggs, milk. Okay. And what happens? Over the years, that builds up plaque, like rust in a pipe. And that plaque does what? It slows down blood flow. It limits blood flow if it's really narrow. Listen, if you want low-fat milk, go get yourself some whiteout and a glass of water. Put 2 drops in. Low-fat milk is also high in fat. Third degree can be MI, myocardial infarction. Digitalis can cause third degree. So, etiology, third degree, CAD, coronary artery disease, myocardial infarction, congenital heart disease. It can also cause it. All right, moving along, go over to page 154. Look at the second paragraph. Third degree AV block, like Moffitt's 2, can quickly progress to ventricular standstill with little or no warning. Sometimes you have to get a pacemaker in. All right. Here's what I think I'm going to do. We'll slow this down just a little bit. I'm going to stop for today, but I'm going to give you other little things tomorrow. And once again, you know, I catch myself in mistakes and I have to look down again and say something, you know, so just bear with me and we'll get you through. God bless. You guys have a very nice evening. Okay. Call me with questions. Bye-bye. I can't.